Here I am at the EANM meeting in Birmingham, and I've got Jens Christopher Georgi from Siemens, who's going to talk about PET-MRI. Now, PET-MRI is very new to the scene, and it's the newest multimodality imaging. So what we want to do is to talk a bit about PET-MRI and how that works. So, can you tell us a little bit about? Let's start by asking about what you do at Siemens.
So I'm the global product manager for the Biograph MMR. Outbound, this means I'm representing the product to our customers, to the outside world, and as that I'm basically responsible for the whole marketing campaign around the product and the marketing material.
Currently, is this a product that's being used in the clinical circumstances?
Indeed, we have the first clinical installation. We have had it in November last year in Munich. Technical University Munich was the first clinical installation, and there the first applications are going into clinical routine. That will be a glioblastoma follow-up protocol where PET is combined with MR. Before the Biograph MMR it was on separate systems, but now it will be run on the Biograph MMR due to better spatial registration and also patient comfort and workflow aspects. We also have the first private installation now in Germany, in Bremen. It's a private imaging center, the PET-CT and MR center in Bremen Mitte, the CMODI, and they are really using it only for clinical routine imaging. So they really want to use the workflow aspects of the system.
So this is not a pie-in-the-sky product. It's a product that's actually out there. I suppose the one question is I mean, we've had PET-CT for a long time. Why haven't we had combined PET-MRI? What are the technical challenges to having PET-MRI?
In PET-CT systems, photomultiplier tubes are widely used, and their physical principle is basically to use the acceleration of electrons in electrical fields. And this physical principle is completely disturbed by the static magnetic field that we have in a MR PET system. So basically photomultiplier tubes cannot use there. What we in Siemens now did is we replaced the photomultiplier tubes by avalanche photodiodes, the so-called APDs, and they are insensitive to static magnetic fields, and to the dynamic magnetic and electromagnetic fields we shielded those.
Okay, so you've managed to really change the way the detectors work for the PET systems to make it work. Are there any problems with these things compared to the conventional photomultiplier tubes?
The APDs compared to the photomultiplier tubes have a relatively high price. This is basically translating into the system price, and the APDs compared to photomultiplier tubes have a relatively lower temporal resolution, which makes it then not possible to do time-of-flight imaging at the system.
Okay, so but you can use the advantages of the MRI in that sort of thing. So let's have a look at some of the things that you could do with a PET MRI that you couldn't do with a conventional PET-CT. Well, let's start with perhaps something people think you might not be able to do, which is attenuation correction, which is the original reason why we had CTs in PET scanners, because you can scale or segment a CT fairly. You're dealing with ionising radiation. You can scale it so that it's a bit like attenuation for positron emitted photons. But you don't have that in an MRI. You're dealing with radio waves. So how could you possibly do attenuation correction?
So this is let me talk about this in a, let's say, historical context. We worked on the topic of MR PET for years with our clinical partners, for example in Tübingen or Jülich or the MGH in Boston, and there we started with a prototype of the Biograph MMR, which was a dedicated neuro PET insert to 3 Tesla MR systems. And there we not only worked on the electronics, which then led to our now used MR compatible PET detector technology, we also worked on the software, namely attenuation correction. And in terms of attenuation correction, we developed with those partners dedicated MR sequences, the so-called Dixon Vibe sequences. And these sequences allow us to differentiate different tissue classes. And based on the Dixon Vibe images that we acquire of the whole body, we can segment different tissue classes, namely water or soft tissue, fat, air and lung. So air and lung is differentiated. And into those segments we derive from the patient-specific images. In those segments we then can fill in the known physical properties, the mu values, and those are then used to derive a mu map, which is the input to scatter and attenuation correction using the same algorithms that we also have in PET-CT. And this is the patient attenuation and scatter correction. For the hardware, namely those hardware components whose position we know during the imaging, we also have an automatic hardware attenuation correction. Basically, we scanned those components in a CT and use this then, those CT maps or attenuation maps to correct, for example, the head and neck coil, the dedicated PET-compatible MR head and neck coil, or the spine coil, or the patient table as well.
Right, because think about it, you're not just imaging a patient, you're also imaging a scanner as well as a patient inside a scanner. So you could take some pretty good diagnostic images of your camera if it was broken. Yeah, so that's an interesting idea. I hadn't thought of it. But in many ways, what you're doing is really what they do in attenuation correction in CT anyway. Yep. Yeah, I mean, people think about it as that, but what they really do, because Hounsfield units aren't directly compatible back to gamma rays at particularly at 511, because then they're not directly compatible back. We already segment it, and that's how the attenuation correction works in CT. Am I correct, or am my physics wrong here?
No, exactly. Even for the PET-CT world, we have an approximation of attenuation in the CT energy window, which is around 120, 140 keV, and we have to translate this to the high energy PET photons at 511 keV, and there the physics are already a little bit different, and this transition from CT energy to the high energy from the PET also is an approximation also for the CT based attenuation correction. And this is basically this difference, or what you have in your mind most often is CT images with a large contrast between soft tissue and bones. But this is only true for the low energy, the 120 keV for example. At 511, our PET photon energy, this difference is not so large anymore. So the difference in attenuation in soft tissue and bone for the PET photons, not for the CT, for the PET photons, is much smaller than it is for the CT. And this is basically the reason for our attenuation correction, which for the body does not take into account the body, the reason that it works so well. So we have a study at the Technical University Munich where they showed the maximum error of deviation between CT-based attenuation correction and our MR-based attenuation correction. This maximum error, of course, is for a lesion which is directly located to a bony structure. And even for this worst case scenario, maximum error was between 5 and 13% deviation. So this physical effect of different energy photons having different interactions between matter. This is in favor of us for the fact that we do not take into account bone segments.
Yeah, I mean, that's really what CT attenuation correction does anyway. It really does. It produces a segment map, and the physics are different. You've got photoelectron effect more than Compton, and more Comptons for the 511 photons. So there's actually physics reasons why segmenting is needed for when you do CT, and you're already doing segmenting when you've got MRI. So it's really not as big a jump as you might think. Okay, so you mentioned before there could be some artefacts next to bone. Are there any other problems or artefacts along those lines?
I would not say an artifact at a bone. I would say a difference to the CT SUV value. It's just a difference. Where we, as well as the PET-CT, have problems is metallic implants. So for a PET-CT, the attenuation around a metallic implant is overestimated. In our case, metallic implants in the MR lead to signal voiding. Signal voiding means basically underestimation of the attenuation because we take it for air, basically. So for metallic implants, it's important to take a look at the MUMAP, to take a look at the attenuation corrected image as well as the non-attenuation corrected image, but this is true for PET-CT as well.
Okay, so truncation might be an issue because you're dealing with different field of view. Presumably arms and arms up, that type of thing. That's an issue.
Truncation is an issue, and we found a solution for that. It's the MLLA algorithm that we developed to take the outline of the patient's body basically from the non-attenuation corrected PET. This knowledge is then transferred into the generation of the MUMAP, and then we bring together this information with the Dixon Vibe sequence and can take into account also the arms that are actually not in the field of view of the MR, but we get the knowledge from the PET images.
Okay, so are they the main pitfalls? Are there anything else that should be mentioned as a pitfall? Perhaps we can talk about the strengths then.
No further pitfalls in that sense. What one has to take care of is workflow. That's the exciting part of a new system right now, to define clinical workflows for the routine in the future.
Okay, so some of the advantages in terms of the physics, I mean, one of the things that MR suffers from is movement, so they've developed ways of doing movement correction in MR. Can we take that movement correction and use that to help us with the movement, the inevitable movement we get with a very slow PET scan, or relatively slow, not very slow because you've got a fast PET scanner, but can you use that MR information to improve the quality of your PET scan, for example, with movement?
In MR, we have been working on MR sequences to track, for example, the diaphragm. And those sequences have been used for years now in MR for prospective gating. So basically what we do in MR is to track the diaphragm, and when we are in expiration or inspiration, we can choose, then we are doing the diagnostic MR scans. This information we get from the dedicated sequences for tracking. This information can also be used for the gating of the PET. And there we basically leverage the simultaneous acquisition. We can really use the MR for quantification, for detection of motion, and use this information then for the correction of the PET images. What's available right now on the product is tracking the diaphragm, and also the heart motion for gating. What we are currently working on with our collaboration partners, for example in Tübingen and the MGH in Boston, is basically going one step further. Currently when you do gating, you still chop up your list mode stream into different gates and phases. Each of those phases then only has a subset of images. What we would like to derive and where we would like to come at is extracting a motion vector field from the MR and use this to do the correction of the PET and get one motion corrected image with all the counts in there. And this is something we are looking for in the future, to really get real motion correction rather than motion freeze.
Right. So that immediately brings on some clinical applications that can't be done on anything but a PET-MRI. I mean, a good example I can think of straight off the top of my head that you said there, you could use FDG, for example, to look at inflammatory markers in the coronary arteries, so you can look at vulnerable plaque. Yep. And I know there's been some studies in trying to gate and deal with that from Finland, and it'd be great. It'd be great to see some of that kind of work that couldn't be done on anything, but a PET-MRI. So would that be one thing? What other things? Perhaps head and neck, where you've got soft tissue that you really want to characterise?
There's a number of applications where we think the MR-PET, the PET-MR, will replace the PET-CT in the future. However, and let me state this very clearly, we do not want to make the impression that the MR-PET will replace the CT for everything. So there will be applications for the PET-CT and there will be applications for the MR-PET. And this is what we are currently defining and finding out with our clinical partners. Very important applications are those where we benefit from the improved soft tissue contrast of the MR versus the CT, where we benefit from the motion correction capabilities, where we benefit from the dose saving aspects of PET-CT versus MR-PET, and also, and this is very important, where we benefit from the functional capabilities of the MR. So the MR basically has two aspects, the anatomical but also the functional capabilities. And cases where we benefit from all of those aspects is, for example, liver. In the liver, which is already very close to the lung, and it's also kind of being impacted by the breathing motion, we have the benefits of motion correction. In the liver, we have the benefits of the improved soft tissue contrast of MR. In the liver, we also can use dynamic contrast enhanced MRI sequences, diffusion weighted MRI sequences, in addition to the anatomical MR sequences. And so this is one of those aspects where it all comes together. Furthermore, I would like to say head and neck. Brain studies, neurodegenerative disease will come with new PET tracers being thrown on the market. But also the pelvic oncology, male as well as female, prostate and ovarian, cervical cancer. These are very interesting fields for MR-PET.
Yeah, I mean, there's lots of soft tissue things that aren't seen very good on CT, so they're the things that are going to benefit, but also the flow things. For example, you said in the liver, if you wanted to see whether there was vascular supply to a region, but you also wanted to see whether there's viable alive cells in a region. Let's say you were going to target your therapy for dealing. You want to know which part of the liver you need to know. You need to know which ones have got the blood supply and which ones have got the active cellular turnover. Or if you're developing a new pharmaceutical, you want to be doing that sort of work as well, I presume. Would that be a valid situation? And you mentioned about dose saving in paediatrics. You want to be reducing your radiation dose as much as possible. One you didn't mention, what about iodinated contrast? If someone's got a problem with iodine, or if you've got someone who's got renal disease where you have iodinated contrast, you're going to be dealing with that. So there's a whole host of applications which I think maybe uniquely you could only do this way.
Also, let me mention repeated studies, longitudinal studies in therapy monitoring or therapy follow-up. So those repeated studies will definitely benefit from the both dose-saving aspects and also from the patient comfort aspect. So having a patient regularly on a PET-CT and MR, for example, follow-up of glioblastoma patients, that's definitely an improvement also in patient comfort to have them at one single exam rather than having two exams at 2 different days, for example.
And with increasing regulatory surveillance of radiation doses, it's very important to reduce radiation. And with some of the PET tracers with very short half-lives, that means that you can have a very low radiation dose examination, and that may be particularly important in many aspects. So this is going to be, there's a whole host of applications straight off the top of my head that I can think of where you'd really want to be doing that. Perhaps there's some areas though that have already been highlighted in terms of clinical applications where the CT's got some superiority, and that's in the chest, I presume. So we're looking for, pulmonary lesions, perhaps maybe better picked up on a CT rather than on an MR.
Small nodules in the lung definitely is a field where the CT is superior to the MR at the moment. However, we are also looking into the capabilities of MR to be improved on that. So we are looking dedicated MR sequences for the lung to also pick up those small nodules that are important to know about in patient management. So there we are also going next steps in MR imaging.
Right, and quite often, particularly where you've got subtle cellular changes on an MR, you've got a very poor signal-to-noise ratio, so you're not going to pick up a lot of the individual cellular type functions. Whereas in nuclear medicine, you've got a very good signal-to-noise ratio in terms of background, but you've got poor resolution. It seems like a match made in heaven in terms of picking up those subtle changes. Exactly what you want to do in radiopharmaceutical development, where you're trying to optimise and only develop radiopharmaceuticals that are going to work.
Yep. So I think for radiopharmaceutical development, for example, combined probes, probe where you have a F18 stick to and a gadolinium maybe within the probe, that's very interesting to have a combined probe to really make use of the simultaneous acquisition as well. And that's also something we are very proud of. We are having the largest detector in Z direction with 26 centimeters, 25.8, and having a dynamic study, for example, for drug development, allows us to have in the head and neck area, we would have the complete brain in the field of view, as well as the carotid as the input function, or we could have the liver and the kidneys in one field of view. So those aspects of dynamic PET imaging, dynamic PET and MR imaging, we really benefit from the size of the detector. And besides this, the size of the detector directly translates into the detector being the highest sensitive PET detector currently available. Even in our own Siemens portfolio, we are having 40% higher sensitivity than the MCT with a TrueV extension.
Right, so that means that you're doing your PET scan in a very short amount of time, a similar amount of time as your MR scan, so that you're very efficient. You're using both machines in maximum efficiency, which is often one of the questions that put up and one of the problems put up. So it's also about using both machines in maximum efficiency. In a CT, you're only using it for a fraction of a second, and then it's the rest of the time it's sitting around waiting. Here, you're using both machines all the time, or much of the time. So you're really enhancing efficiency, and that's important in these cost-conscious times.
Exactly. So this was one of the reasons for us to expand the field of view to this 26 centimeters to match it a little bit better with the 45 centimeter field of view in C direction of the MR, to have a better match between those field of view, because actually our exam is still very similar to the PET portion of a PET-CT. We are going bed position per bed position, and this is more or less than the advance of the bed position triggered by the field of view of the PET. And from bed position to bed position, we are always acquiring MR and PET at the same time, and this is the efficiency benefit that we have.
Well, very exciting. Is there anything else you'd like to add? I think that's really an exciting move, and I know that that's been a real buzz around here at the moment in terms of places that are going to be getting these machines and really making strides. I can see some massive strides, particularly in therapy, in cardiac disease, in oncology, that really this is going to lead. It's going to really change medicine as a whole. Even if it doesn't change some imaging, it may change the way we do medicine by finding out information that'd be useful for treatments and validating treatments.
So something I would like to say here is we have CE labeling. We have the FDA approval, and basically we are getting more and more approval around the world. However, what I'm very excited of and proud of is the collaboration with our collaboration partners also around the world, and they are the ones that will define the clinical routine applications for MR-PET in the future. And this is something that will not come from Siemens. We are supporting them, but we are an engineering company, basically. And our clinical partners, they are the ones that show the world how to use such a system. And this is what's so exciting about my job as well.
Excellent, yes, dealing with the clinical partners. So thank you very much. That's very interesting. Much appreciated. Thank you.